Okay, now I invite Dr. Shelly Sharma to present her next topic on imaging directed breast biopsy. Dr. Shelly Sharma is working as a consultant in the Department of Radiology, Sir Gangaram Hospital. She has done fellowship in oncoimaging from National Cancer Center, Singapore. She has done observership in breast imaging at Mayo Clinic, USA, and she holds a certificate of merit at RSF Meet, Chicago. So now I invite Dr. Shelly Sharma. She is enthusiastically doing a lot of breast biopsies in Gangaram Hospital, and she has a very vast experience of breast biopsies. So invite you to talk about the same.
Very good afternoon to everyone. I'm presenting from Breast Imaging Department of Sir Gangaram Hospital. Me and my senior Dr. Madhvi, we are working in this department, and we are very thankful for this opportunity. So as Dr. Rakesh Kaul has discussed when to biopsy, I'll just be adding one final point here that we biopsy whenever the clinician or the patient has a high suspicion. So apart from lesions which are BI-RADS 4, 5, and 6, in which one should biopsy, we can also biopsy when the lesion is BI-RADS 3 and the patient is apprehensive or the clinician feels the need, then we can even biopsy a BI-RADS 2 or a BI-RADS 3 lesion, in which the chances of it being malignant are very less. Whether one should go for imaging guided biopsy or blind biopsy. So there was this study, which was a prospective study, which was done by our colleagues in AIIMS, New Delhi, in which they compared palpation-guided biopsy results with image-guided biopsy. And they found that image-guided biopsy had a higher diagnostic accuracy of 97.2% compared to palpation-guided biopsy, in which the accuracy was only 55% approximately. How should we approach breast interventions? Breast interventions can be done under guidance of all the modalities which are available to us for breast imaging, namely ultrasound, mammography, and MRI. But how do we decide on which modality we have to biopsy is that on whichever modality the lesion is best seen, we biopsy the patient on that modality. The most favored and most practical one is ultrasound guided. But if the lesion is not seen on ultrasound and it is seen on mammography, then we undertake the patient for a mammography guided biopsy. If it is not seen on mammography as well and only seen on MRI guided, then we can do a MRI guided biopsy. But out of all of these, the easiest, cheapest, and best for the patient would be an ultrasound guided biopsy, in which the patient is lying comfortably and the radiologist is also comfortable maneuvering the needle under the guidance of ultrasound. So when the lesions are seen on mammography or MRI, sometimes and not seen on ultrasound, then we do a second look ultrasound. We call the patient back and try to localize the lesion in that particular area. And if we can see, then we go for an ultrasound guided biopsy. What is the intent of tissue diagnosis? It is first for the confirmation of malignancy, to know the histological grade of the tumor, to know the hormonal status of the tumor, and the recent oncotype diagnostic test can also be done on these tissues. I mean, you would know better than me. Core-needle biopsy is the most favored of all. It is a cheaper, easily available biopsy, which is available to us here in India, where there is no insurance coverage to the patient. World over the world, the places where there is an insurance cover, they have moved to a higher biopsy, which is vacuum assisted breast biopsy. But because of the cost constraint, we stick with core needle biopsy. In it, the patient lies comfortably on the bed. It's a OPD procedure, and all in all, it takes around half an hour. It is a more accurate, it gives low false negatives, gives us an adequate sample size, and it's a OPD procedure. However, in certain cases, an excisional biopsy may be suggested if there is a radial scar or if there is atypical ductal hyperplasia. This was a 34-year-old female with dense breast, and there are these two circles which I have put. There is focal asymmetry seen on tomosynthesis and ultrasound. There was a mass which was biopsied. So I have included the video of the biopsy. This is just to show the procedure of core needle biopsy. The lesion is seen in the center, and I'm approaching it from the left corner of the screen, and you can see the needle in profile. And also the lesion is sitting very closely on the pectoralis muscle, and below that you can see the lungs moving. So ultrasound not only helps us in better localization and targeting of the lesions, but also helps us in preventing certain complications which can happen, especially if the needle punctures through the pectoralis major, it can lead to pneumothorax. We are also doing this vacuum-assisted breast biopsy procedure, in which it is a kind of core needle biopsy where in the core needle, we use a gun of 14 gauge, but in vacuum-assisted procedures, we use a 11 gauge gun, and it gives us a higher tissue, and we can target it multiple times. From 6 to 12 times, we can target the lesion in one go. And the vacuum is used to collect the tissue. I'll be showing you a video once we finish with this talk. So this vacuum assisted breast biopsy is better in cases where there is a failed core needle biopsy, where the lesion size is smaller, where there is architectural distortion, clustered microcalcifications, or intraductal lesions. All in all, when the lesion is very small, and if we do a core needle biopsy, sometimes the lesion tends to get lost. So in those cases, a vacuum-assisted breast biopsy is better. But because of the cost constraint, it is almost 4 times the cost of a normal core needle biopsy. We have limitations with this procedure. It can also be used for therapeutic excision of fibroadenomas, especially in young girls who want to have a scarless. Stereotactic breast biopsy is when the lesion is only seen on mammography. For example, these are microcalcifications or non-palpable lesions. In that case, we take the patient on our mammography unit. There is an attachment which comes with it, which helps us in precise localization of the tumor on our screen. The machine helps us. It's like a robotic arm, which helps us in exactly localizing the depth, and the site of the tumor. And through that arm, we insert our gun, and we are able to localize the lesion. Just a few here and there, error can be there, but we can tweak it, and we can target the exact lesion. So it is meant only for lesions which are seen on mammography and not seen on ultrasound. On the leftmost image, you can see there are these small tiny dots, and there are these 2 plus signs. So these 2 plus signs are used for targeting the lesion, or these are our coordinates. The small dots are the microcalcifications in the breast which are seen. The middle image shows a gun going through the arm into the breast. And in the last image, you can see there is a hematoma which is formed, small round thing. And there is a very small clip which is seen, which is placed in that area post biopsy to localize that lesion whenever the surgeon wants to take it out. Later stages, post the biopsy status. We also do hook wire localization. It is done for localization of non-palpable lesions before surgical excision. It can be done under mammography or ultrasound guidance, depending on which modality we are seeing the lesion better. Once the hook wire has been placed in situ, the patient is sent to the OT directly. And in the OT, the hook wire acts as a guide for the surgeon to take out the lesion. So this was one patient in which on tomosynthesis only we could see this lesion in the right breast. And we did a hook wire placement under mammography guidance. And this is the post hook wire placement mammography image. On the right is the specimen mammogram, which was done after the surgeon had taken out the lump with the hook wire. We do clip placements, which are done before neoadjuvant chemotherapy for localization of lesions, because post chemotherapy, the lesion tends to dissolve or go away. And when the surgeon wants to operate the patient later, once it has downgraded, then the lesion may not be seen on imaging modalities. So clip placement helps in exact localization of that lesion. Using this clip as a marker, we can put in a hook wire for the surgeon to localize that area. And based on prior imaging, the surgeon and radiologist can discuss about what area needs to be taken out on surgery. We also do clip placement post biopsy in those cases where the lesion size is very small and we feel that post biopsy that lesion will be lost or will not be easily seen. We don't, I mean, world over, and also in our institute, we are not doing FNACs because these have very high false negative rates. And though these are easily available, less traumatic and cheaper for the patient, but the material is inadequate and it gives a high false negative rate, low sensitivity. Sample size is not adequate for tumor markers. So we kind of discourage FNACs. But if a rapid diagnosis is needed, if the patient is very sick, or if there is a technically difficult area for biopsy, then we can consider doing a FNAC as well. This was a patient who had come from Agra to us, and she had thrice undergone FNAC. They were very reluctant. They were sent by Dr. Call to us for a mammogram followed by a biopsy. They were very reluctant to undergo a mammogram, fighting that why do I need a mammogram? I don't have any problem. So on the mammogram, there was nothing much seen. There was dense breast parenchyma, but on ultrasound, there was this lesion seen in the right axillary tail. Very small mass. It is not even a centimeter in size. It's around 0.9 by 0.8 by 0.8. So few mm, and but it looked very suspicious on ultrasound. So we did an ultrasound guided biopsy and it came to be malignant. And post that, the patient is coming every year for her follow-ups to us. So that was the thing. And I want to play that video also of the vacuum assisted breast biopsy. So this is from a vendor, we don't have any kind of financial support from him for this presentation. It is just for the sake of showing what new things are there and what we are doing. So this is a vacuum assisted biopsy gun, and world over they are using these biopsy guns now to biopsy breast lesions. It uses vacuum to suck in the lesion into the hub. And once the lesion is there, then the knife kind of comes over it, takes the sample. The sample goes behind into a chamber, which is attached with it. And with one insertion only, we can move the gun, keep moving the gun around 6 to 12 times and take a big chunk of tissue. So it's just showing how it is cutting through the lesion. The vacuum is helping in sucking it back into the system. We need not insert and reinsert the gun again and again. And at one go only, we can acquire 6 to 12 cores in 30 to 60 seconds. This is the chamber in which it gets collected. And once the biopsy is over, there is an option of the cavity which is there. For that, we can also do a lavage at the same time of saline so that there is very less bleeding and very less pain. We have done this in around 15 patients till now, or maybe more, 15 to 20 patients we have done this. There has been no complication, and it gives us a major chunk of tissue, around 100 to 120 grams of tissue at one go. So it is very good for the diagnosis, and world over they are using these guns for biopsies, but because of the cost, the high cost involved, we are not using it very frequently here. So that's all which I have to show.
Thank you, Dr. Shelly. I think that was a very wonderful presentation. The video about vacuum assisted breast biopsy was wonderful, and it's good. And it's good to see that it's being done in your center, and I hope more and more centers are able to. Yes, cost I think is definitely a big factor for many centers. I don't think it is widely available also in India as much, but I can see that it has got great advantages.